Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitians. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes.
Welcome to another episode of Food, Freedom, and Fertility. You have your two dietitian bestie functional medicine hosts here, Caitlin Johnson and Sophia Pavia.
Hello.
You want to say hey? Yeah. And today is kind of a special episode for us. We had a couple reach out to us from Florida, I believe they're in, and they really answer kind of a different area of interventions than most practitioners. Oftentimes we're offered medicine, supplements, procedures, surgeries, and very often treatment doesn't incorporate things like stretching or physical therapy. And at least we don't think of physical therapy first when we think about infertility. And we want to highlight some other areas that you could potentially look for resources. And we are so happy to have Larry Wurn here with us today. Hi, Larry.
Hey, good afternoon.
Yeah.
We have a man on the show. We can probably count the
Shocking.
the number. I know. We can probably count the number of dudes we've had on the show on one hand. It has been not plentiful, but we're trying to be diverse, and so we're bringing in a dude.
There you go.
Yeah.
There you go. Good
So
for
Larry,
you girls.
can you give
Yes.
us a little bit of background for you and your wife and just like how, like you probably didn't grow up thinking I'm going to help women get pregnant.
So my wife I've known my wife since she was 2 months old. We grew up together and loved each other. Got married at her in her early 30s. She was a summa cum laude, top of her class physical therapist at the University of Florida and developed cervical cancer. We went, oh my gosh, well, there's a huge med center here in Gainesville, Florida, which is our center. We now have clinics from LA to London, but we went in and the doctor said, well, you need to have a surgery and you need to have radiation therapy. What's the radiation therapy like? Well, we're going to give you 40 external treatments, and then we're going to take this shaft that looks kind of like the metal shaft you put a cigar in, and we're going to fill it with irradiated material. We're going to surgically implant at the full depth of your uterus and set you there in the room for 72 hours. Don't worry, we'll keep you sedated, but you have to understand it's dangerous for us to be in the room for more than 5 minutes, but we're going to keep you there for 3 days with this stuff inside of you. And then we're going to do it twice. So this is leading up to the infertility part. Okay, so
Well, I can imagine.
afterwards, of course, nowadays that procedure is done for a few seconds at a time, but she got 144 hours of it. It was in debilitating pain from adhesions afterwards. What are adhesions? Well, they're a huge problem in medicine, in all fields of medicine. They are the internal scars that form largely in women and a lot in their reproductive tracts, and I'll talk about it. And surgeons simply overlook these. If they're bad enough, they'll go in and do surgery and remove them. They think they're removing them, but the surgery almost inevitably causes more adhesions because you have to heal from the surgery. So being raised that the prince marries the princess and they live happily ever after, and that wasn't happening. She was in just debilitating pain. We started taking courses, advanced courses in America and in Europe, in everything that we could find that would decrease adhesions without surgery. Nobody in medicine had ever thought of this. They didn't need to do it. They knew they could just do surgery, move on. So we did get her out of pain and developed
Which is no small matter.
no
Hooray.
small matter. She went from debilitating pain to working 40, 50, 60 hours a week after it took us a couple of years to figure that much out. And then we were totally shocked when patients we were treating for pain, patients we were treating came back and said, I'm pregnant. And we said, well, that's great. Congratulations. You don't know. No, you don't understand. I've had totally blocked fallopian tubes for 7 years. I've had the same boyfriend the whole time. The only thing that was different was that you treated me. And
Mm-hmm.
oh, okay. Well, this happened 2 or 3 times. And um, chiropractor friend sent his wife. She was 41, had only one fallopian tube, and it had been blocked for 11 years. Severe endometriosis from a filed 1.5 inch thick. He said, if you could even just get her out of pain, that'd be great. Well, she comes in one day, halfway through treatment. She says, I don't know whether to hug you or hit you because I'm going to be 42 and I'm pregnant.
Oh
And,
my gosh.
she was shocked. So we wrote to the gynecologist in town and said we were helping a lot with intercourse pain and period pain, which we'll talk about further in this, but that we were opening blocked fallopian tubes. Well, the chief of staff of the hospital, a huge hospital next to us in Gainesville, Florida, where the University of Florida is, called me in. He said, Mr. Wurn, what is this about opening blocked fallopian tubes? And I said, Dr. King, here's a half dozen charts I brought. Take a look at them and you tell me. After he looked at about the first 4, he said, sir, he says to me, you're doing things with your hands that I don't think I could do surgically. And I said, is that okay? He goes, well, yeah. He said, that's remarkable. He said, I'd like to know more about it. And I said, well, this is what we do, and gave him the history that I had just given to you and your audience. And he said, we need to do some research on this. And would you like me to help you? And I said, absolutely. And so he joined us as research director and medical director, never charged me a cent. He's never made a cent out of us. He's never asked for anything other than he was raised in a house of women, as I was, and just wanted to help. So we started conducting some research, and I can just dive right into it if you'd like.
Yeah, tell us all about it.
Okay.
Yeah, so basically, Larry, what you are telling us today is that you're here to talk with our audience about how adhesions, block tubes, physical problems within the uterus, within the reproductive tract, have treatment options outside of simply surgery and medication, that there is body work and therapy that can be done with wonderful results, and it is an option often unexplored.
Absolutely.
Awesome.
And to do this, I mean, I like to look people in the eye and say, this is what we can do and this is what we can't do, especially working with the chief of staff. He was a researcher as well as a surgeon and gynecologist. And so we've had a dozen studies published that are part of the National Library of Medicine on this work and treating various types of infertility. Let me talk about adhesions for a second and what happens when you... and why women are more susceptible than men are to this.
Yeah, let's hear it.
From the time, when you're a kid and you're learning to roller skate or you're coming down the sliding board, you're learning to walk, you can fall on your tailbone and get some inflammation there, and it hurts, and sometimes you can get really whacked there. And then as you get older and you start to have periods and then you start to have intercourse, things are entering you and entering this warm, moist, dark environment of your vagina that are not always sterile and generally are not sterile. Well, in that environment, it's a perfect place for bacteria to form, and the body's first response to any sort of tissue trauma or tissue injury, whether it's an inflammation, infection, surgery, or a fall, a trauma, is to send in adhesions. So adhesions form naturally. They are internal scars. When you cut yourself, a scar forms on the outside of you. When you have an infection and inflammation, endometriosis causes adhesions. So adhesions are tiny strands of collagen, little threads. They're microscopic, but they're stronger than steel by weight. They're kind of like strands of a nylon rope. They lay down on top of each other and start creating an internal scar. Okay, so that they can stop any bleeding if there's bleeding happening, prevent bacteria from going to other parts of your body. Then your white blood cells and your immune system go to work, and you hopefully heal from that. But once you've healed, that internal scar remains, and it's there pretty much for your entire life. We have a scrapbook of adhesions, and all of us, where we've healed, in most cases, they don't really cause problems. But when they occur in the vagina, for example, and these are uh, they are basically invisible on microscope. You could see them in a microscope if you could get a microscope in there, but they're so tiny but very strong, they can cause intercourse pain because the tissue that should be pliable and move easily, now suddenly it's stuck and it's not able to move. But adhesions up in the fallopian tube, they're the main things that block fallopian tubes. Well, a fallopian tube is at the very top of the uterus. Well, if it blocks right at the very entrance, a physician can put a tube in there, a balloon catheter, and kind of blow it up and hopefully open that up. But if it happens in the middle or toward the end of the tube, a tube is designed to carry a single cell, one egg.
Super small, yeah.
Super small. So they're tiny. So for a surgeon to actually do surgery on fallopian tubes, and this is what the doctor first got interested in, because he'd done surgery on fallopian tubes. He said, Larry, the threads I use are so small, they'll float off in the air. He said, this is so tiny. You risk having...
Like puncturing it almost.
Yeah, or creating more of what you're going in there to fix in the first place.
That's exactly it, Sophia. Exactly it. So when Dr. King said, well, let's investigate and see what you're doing, and this works not just on fallopian tubes, but we'll get into endometriosis and intercourse pain and menstrual pain and PCOS and high FSH, advanced age, because we've studied all of those things with PhDs and doctors that have been interested in us and interested in finding out how this works. So with fallopian tubes, it was really convenient because we could study them. You can get a dye test where they put a catheter, a straw up inside of you into your uterus, and then you and the doctor both look at it on television screen. It's kind of an X-ray, and you can see the dye filling the uterus, and then as it goes out, hopefully the fallopian tube to the very end, and it spills out, and you get hopefully what is called free spillage, where the dye just goes out freely. Okay, that tube is open. If a tube is closed, it's really a problem. And most reproductive physicians these days say, well, we'll just cut that out and go directly to in vitro fertilization.
Yeah.
People don't
We'll
really
just
want to
sterilize
have
you
that.
and then do IVF.
Yeah, that's right. And you'll never
Because
be able to have
that
a
is
child
the
naturally.
Listeners, that's what, if you were to be surgically sterilized, like if you decided you're all done having babies, you don't want to do anymore, that is the procedure, tubal ligation. That's essentially what it is. Either the severance or the complete removal of the tube. And so that's why we're sort of balking at this as fertility practitioners, because really the treatment you're going to offer is surgical sterilization. And that's what we're going to do for you because you want to be pregnant. That's why it's sort of like, this is a terrible idea. We need other options.
Well put, and exactly the case. So we were shocked. So, well, at least with the tubes, we could do a dye test beforehand, then treat them, and then do a dye test afterwards, unless they got pregnant first before we even got a chance to do a dye test afterwards, which happened a lot. And we did that and hired a PhD because I wanted to know why this stuff was working so well. And she said that we had a 69% success rate opening fallopian tubes in women who had never had surgery directly on their tubes.
Wow.
If you've had a surgeon actually cut into your tube, that our success rate is half of that. It's about 35%. Okay. So, but 57% of them got pregnant then. So most of them got pregnant and naturally. So that was really a good sign. Halfway into this, so we started opening block fallopian tubes. Most of the gynecologists in town didn't know we were working with the chief of staff. They really didn't know what to make of us. So we were the odd practice in town using our hands to treat infertility.
Right.
And
You've got the shark solution or the crocodile snake oil.
That's right.
That's what it sounds like from the outside.
That's right. And yet here we were testing them before and after with an independent radiologist, physician testing them. Of course, I don't do radiology. I've learned how to read them a lot.
Sure.
One of the interesting things we found was that we were looking to see if the tubes opened or not. And then I had these pictures on the wall from early ones that we had done. And then for about 5 years, I passed this picture just looking at the tubes. And then I looked at the inside of the uterus. And the inside of the uterus, that is the walls of the uterus of the woman that we treated for blocked fallopian tubes, and we were successful with their tubes, it looked squeezed. It was narrowed significantly. You can see it at our website beforehand and pulled way to the side. And afterwards, it was wide open. It was like a 12-year-old girl's uterus, the interior anatomy would have looked. It looked normal. So we started to realize, wait a minute, these adhesions can form anywhere in the body. They can actually form within the wall of the uterus. If you get kicked during a soccer game or you land bad during an athletic event and you get an injury, and people are always falling in that area is subject to injury anyway, adhesions are going to form. And they're not thinking of fertility. They're thinking, well, I need to stop the bleeding here and help. So those are interesting image before and after images you can see at the website, not just of tubes, but of the uterus itself. So that if you want to have a baby, and if a reproductive physician wants to implant an embryo, would you want to implant it in a uterus that was constricted like this, or in one that was natural, the way it was earlier in life? And as we decrease adhesions, it's like we take the body back to a state before they formed, because they're only necessary to be there during the healing process from that injury. Once you've healed, they're not necessary anymore. The body just doesn't have a way to get rid of them on its own. So that's how we help.
So I know all of our listeners are dying to hear what exactly this is that you do, but let's take a quick break, hear from our sponsors, and then we'll come back and we'll get into what is it that you're actually doing.
We're taking a quick break from this episode to talk about one of our sponsors, the Prenatal Nutrition Library.
We love the Prenatal Nutrition Library. It's a searchable database and app, which means you have answers within seconds and peace of mind that what you're eating during pregnancy is both safe and nutritious.
It's almost like having your own personal pregnancy dietitian in your back pocket that's going to not only tell you, is it safe to eat this, how much of that should I have, yada, 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 but give you actual meal plans so you know how to put it all together onto your plate today. And the meal plans are trimester specific, meaning, some women are kind of nauseous in their first trimester and maybe they need specific foods to help combat that. Prenatal Nutrition Library has got you covered. Or the fact that your baby's brain is growing rapidly in your third trimester and you need your nutrition to support that. Prenatal Nutrition Library meal plans has got you covered there too.
This is evidence-based information. Registered dietitians are in this app weekly answering members' questions. There's an exclusive podcast within the app that's run by Ryan, who is the prenatal dietitian that founded this entire thing. It's a wealth of knowledge and resources and will take you far beyond that one-page handout your doctor handed you that actually probably has out-of-date information about eating in pregnancy.
So head on over to the Prenatal Nutrition Library as soon as you get your big fat positive. Well, okay, first message me and Caitlin so we can do a happy dance with you. Then head over to the Prenatal Nutrition Library to get clear strategies to meet your nutrient needs, as well as to take the stress out of confirming what's safe and most optimal for you and your baby while you're pregnant. Use code FFF20 for 20% off.
We are back. So Larry, as much as we love to hear about how effective this is and the research behind it, I can tell you right now, our listeners are wondering, what is this? What are you doing? How do I access it? I would think that most people that are concerned about adhesions, scarring, and blocked tubes are like sold at this point because, I mean, let's be real. When we talk about the cost, the risk, the recovery of something like a surgical intervention or a medical intervention versus what it sounds like you're talking about, which is a manual therapy, oh my gosh, like why would you not give this a go? Just be simply because it sounds so much more accessible, so much more harmonious with your body and not nearly as much risk. So let's talk about what is it that you're doing? Answer everybody's burning questions.
Okay. First, we have everybody complete a medical history form on
Of
all the
course.
injuries and including all the injuries, infections, and such like that that they've had in life. So we start to get a sense, number one, if we can help them, and number two, where adhesions may have formed, because since they can kind of spread in the body, if they've had other injuries at their leg or wherever that's pulling up into the uterus, we kind of really need to know that. Then all the work is really, I mean, calling it a massage is kind of like calling the space shuttle a plane. It is very slow and deep and very site specific, generally deep, very site specific to adhered areas. So after doing this for now a little more than 30 years, we let our hands sink in. We've read the history. We let our hands sink in and we start feeling for adhered areas. We know how the uterus, the mobility that a uterus ought to have. And whoa, it doesn't really want to pull to
So
the
what I'm
left.
hearing is you're sort of you've learned how to let the body tell the story.
That's exactly right. As a
Awesome.
matter of fact, our patients are invited and encouraged to be part of the therapy team in that let me know all the time what you're feeling. If I'm here and you're feeling it somewhere else, let me know because it's letting me know where that's pulling, you know. And how's that pressure? And because it's generally going to be people like us to work deeper than we actually want to work because they want to get thing
Well,
out
yeah,
of
it's
there.
easy to feel like I know. I've had the same kind of thing like where I've had body work done and I'm
Uh-huh.
sitting there, I'm like, what is this person even doing? I need you to be pounding my muscles. I want to
Right,
hear a crunch, because you
right.
feel like otherwise, what am I paying for? But that's not always the answer to everything. Deeper and more pressure and more is not always the answer, especially with delicate tissues.
That's right. And at the end, we have to like kickstart the motility again. Every organ has its internal movement. So we have to get the ovaries and the fallopian tubes and the uterus back to where they were uh, before all of this happened to you, before the adhesions formed. So doctors tell me, this stuff is like, this stuff is so thick I can hardly cut it with my knife or a laser. How do you think you're breaking these adhesions? They can be like ropes or curtains or like a ball of rubber bands you might see on somebody's desk. So when the thing that occurred for us is when we really studied adhesions deeply because we had to. My wife was in such severe
Of
pain.
course.
We realized that, yeah, those strands are very, very strong, like 2,000 pounds per square inch. You could lift a horse with a square inch of them. But where each strand connects to the next and the next and the next, there's a molecular chemical bond. And that bond is susceptible to dissolving. If we get in there and we put the right pressure and we just stay with it and stay with it, those dissolve. So it's kind of, for us, it feels like a pulling out a run in a three-dimensional sweater in
Mm.
ridiculously slow motion. I mean, it takes a while, but we just work our way through the layers. So it's all hands on. You're lying. A lot of times, our patients are just lying on their back. Sometimes we'll get them up on their hands and knees or have them prone so we can get into the
Prone is
tubes a
laying
little,
on your belly.
laying on your belly. That's right. Um, We will work internally with the patient's permission because, like I said, adhesions do form vaginally, especially if somebody has pain with intercourse. You don't want that. People tell me that I'm going to lose my husband because I can't have sex. I should be having pleasure. So we'll do the same thing, but clearly much more delicately internally on the vaginal walls and also on the cervix.
Just to get everything moving. And you wouldn't think, listeners, that these tissues in your body need to move. I mean, when you think about movement, you think about like your elbow, your knee, your wrists, the joints of your body moving. But these tissues inside of you, movement is medicine there. And when you have things stuck in place, be it from scarring, from tightness, from these adhesions, you have a loss of function, you have an increase in pain. And everything in there is so little, and the movements are so nuanced and so delicate. It's not a gross movement like lifting your arm up over your head. It's not this huge noticeable movement. It's very subtle, very slight, like a finesse. And when these things are not moving, either, the many layers of your vagina are kind of stuck to each other and there's no fluid movement between them, or various communication parts between your reproductive organs are stuck, that is where we're seeing pain. And I'm taking a pause to sort of describe this because so many of our listeners, in just women in general, there's so much blame. I'm just not sexy. I'm just not... I'm frigid. I don't have the desire. I don't have, whatever it is. I'm not sexy enough to do, I don't know, what you see in movies, which is like, or I'm broken.
Like, sex doesn't feel good. Something's wrong with me.
Something's wrong with me. Exactly.
Maybe there is something wrong, but it's not with you. It's your tissues. And there's such an application even beyond getting pregnant or sexual desire and sexual fulfillment. But like the goal here for our listeners is pregnancy and a baby. And
not
you
just
want to talk about
family.
Well, but you want to talk about movement? Your uterus grows bigger than like a watermelon when there's a baby and all that fluid inside of it. So just imagine these adhesions growing and stretching as your uterus grows and stretches. And so there seems to be a therapeutic quality to this type of treatment that may have applications not just to obtain pregnancy, but to feel well in pregnancy and decrease some level of symptom or discomfort in pregnancy itself.
Well, and then beyond that, my practitioner, the midwives that I worked with for both my pregnancies, they are bodywork specialists, and they do something called a breech release, where it's deep bodywork, similar, I assume, to what Larry is describing. And it's the same kind of thing: tightness, tension, adhesions, issues that keep your uterus from moving naturally. And this affects the position of your baby. And so things like breech birth, anticyclitic, I'm saying that wrong, but not symmetrical descension of the baby during labor, sunny side up baby anterior, posterior positioning, these kinds of things. Of course, these can just be natural things. Your baby knows how to be born. And sometimes this is exactly how your baby needs to be positioned to be born. And that's fine. And it's not a pathology. But a lot of times, a reason a baby won't be in a good position for birth is because mom's body is holding trauma in these ways. And so we're not just talking about fertility. We're talking about the sex leading up to trying to get pregnant. We're talking about your body being able to implant, to actually get the sperm and egg together and that to implant into that healthy uterus. And then we're talking about pregnancy repercussions and birth repercussions that carry with you lifelong and your baby lifelong.
That's right. That's right. Because you want to be free. Once you become pregnant, you really don't want these adhesions inside of you because it can cause other problems, including, of course, miscarriage. But you want to have an easy pregnancy.
And an easy birth, damn it.
Yeah.
Amen.
Yeah.
I don't want to push out a breech baby. out of here with that. It's hard enough when they're head down. Both my babies have been in great positions, and I was sure that I was dying when I was in labor.
I have an interesting story that may be pertinent to some of your patients. We had treated a few women, only about 8 or 10, and we were having some pregnancies, and we were referred by a doctor. We were referred this woman. She said, Larry, I've already scheduled an IVF, but can you help me? Because I've had 2 IVFs before, and they both failed. And I said, well, I don't know. Let's see, So I started treating her, and when I was internal, I said, that's interesting. What's that? I said, your cervix, the entrance to your uterus, is kind of curled up and attached to your uterine wall or your vaginal wall on the side. And she said, oh yeah, I can tell you about that. Really? She said, yeah, my reproductive physician has done these 2 IVFs with me before, both of which failed, but he always has such a hard time getting the catheter into me because the cervix is so curled. Can you do anything about that?
Okay, other Caitlin, I hope you're listening.
No kidding.
Okay.
We had a patient on here. We just had someone on. We sort of did like a live review with one of our patients in a previous episode. Right. And this was her exact issue, is they couldn't do the HSG. Well, we did an
IUI, but they didn't, he wasn't even sure he got all the way through the cervix. You're like, well, then you didn't do an IUI.
That's right.
Well, same thing to even get the imaging done, to do the contrast HSG. She couldn't even do it because her cervix, they couldn't even get in through the cervix.
And think how hard that makes it for the sperm to get in. So this is narrowing down.
Talk about pain. That they tried to ram that cervix or the catheter in for over an hour on this poor patient.
So I treated her. So I said, well, let's see. And I treated her, and we worked a lot on the cervix. Plus, the cervix is right in the middle of the vagina of everything where bacteria could come in. And I treated her, and she came back, and so I had about 2 or 3 sessions with her. And she came back after her IVF. I said, how did it go? She said, well, number 1, I'm pregnant. I said, that's great. She said, yeah, but that's not really. She said, that's cool, but listen to this. She said the
small potatoes on the new life, but listen to this.
He says, the surgeon grabs the catheter and he goes, and I can tell he's already sweating and worried about it going in, and it just goes right in. And real quick, he grabs my chart, I think, to make sure I'm the right person. And because he doesn't want to implant the wrong person. And afterwards, he said it was about the easiest transfer he had ever done.
Wow.
So these adhesions form anywhere. And just like you were saying, Sophia, about how delicate the tissues are, and as I was saying, how they can form, these adhesions can form between muscle cells, between the cells that comprise the structure of the uterus and the cervix. They can tighten things and curl things. They're like internal straitjackets. We had another interesting situation where a woman called. Belinda and I were the only therapists at that time, and because we hadn't taught anybody else, we were the only ones who knew this stuff. So this woman calls up and says, Belinda, something really unusual happened. She was like 47, 48 years old. We were treating her for other things. And what is that? She said, well, it's a little embarrassing. Belinda goes, well, are you going to tell me or not? She said, well, yeah, tell you the truth. After I came home, I've been having orgasms like I've never had in my life. I mean, these are real toe curlers. And Belinda, being an appropriate therapist, says, is that okay? She says, well, yeah, it's great. But I mean, it was so unusual that I just had to report it to you. Well, this happened quite a few times. And Belinda asked me what we wanted to do with that information. I said, look, don't even mention it. We're already the weird practice in town. I don't want to.
We don't want to turn ourselves into the next Masters and Johnson here. We don't want to creep people out.
That's right. But then we were at dinner one night with the chief of staff, and we told him about it. He said, you're kidding. No. He said, there's nothing we know how to do about that as gynecologists. And I said, really? He said, yeah, this is actually quite important, and there are 6 domains of sexual function. We can actually measure this and do a study and present it. And I said, really? He said, yeah. So we did a study, And we studied the 6 domains, and we improved every one of them really pretty dramatically, well above 50%.
What
50
are
to
these 6
96%.
domains for our listeners?
Desire, which is libido. Arousal, how excited you get. Lubrication, is everything getting lubricated real well? Or are we getting kind of dry there? Orgasm, had quite a few first-time orgasms in these studies after we treated. Satisfaction, how great did that feel afterwards? And the last one, and perhaps the most important for so many women, is pain. The pain decrease was in the 90 percentiles, like 94, 96, 98%. And the 3 different studies we did in the general population and in women with endometriosis, orgasm was the lowest, only 56% improved. Most of them was 70 to 80% for desire and arousal and lubrication. So I ended up presenting to the American Society for Reproductive Medicine. This is the Society of IVF Physicians, an oral presentation, and they published that abstract in their journal back in 2006. So we've been at this a long time.
Wow.
So the guy with snake oil in 2006 is now presenting to the most educated and advanced doctors that are working in reproductive medicine. That's pretty cool.
Wow, I'm glad this is becoming more mainstream. Well, let's take a quick break and hear from our sponsors again. And then when we come back, we'll have you teach us a little bit more about what you're doing and how people can access this.
Hey guys, we're taking a break from our episode, and I want to talk about something that's super confusing. When you head down the supplement aisle and you're looking for a prenatal, and on the prenatal bottle itself, it says, do not take if you're trying to conceive, pregnant, or breastfeeding. Like, what the heck?
Yeah, it says talk to your doctor if you are pregnant, could be pregnant, breastfeeding, postpartum, whatever. And every supplement has this. You go down the supplement aisle, you go shopping on whatever supplement website, and there's a disclaimer on every bottle of every single thing, which means that everything that you've been taking your whole life long is now a big question mark about whether or not you are potentially harming yourself by taking something where you're trying to be healthy. So that is why we partnered with Needed. Needed is a perinatal nutrition supplement brand that has a wide array of products specifically designed for women who are pregnant, trying to become pregnant, breastfeeding, or postpartum. So it's not just that these products like can work if you're in that situation, or oh, it's probably okay if you take it while you're trying to conceive. No. These products are researched, they are formulated, and they are put together specifically for women who are trying to conceive, pregnant, breastfeeding, and postpartum.
This answers so many questions. I always get asked, like, what can I take? It's cold and flu season. What's safe? Needed has an immune support. That's safe whether you're trying to conceive, pregnant. It's even safe for your little ones.
And it's not just immune support. They've got collagen, they've got hydration support, they have digestive support, they have prenatal multi. They even made a line for dudes.
Needed is somebody we're really proud to be partnering with. So head over to their website and use code FFF20 for 20% off your order.
All right. Well, we are back. So Larry, we want to ask a little bit more about, so this is a hands-on therapy, and you've made the statement that you're located in Florida, and that for a long time it was just you and your wife. What's the practice like now? How accessible is this to the average Jane?
We've trained. It's hard to find therapists that we can train because we want them to be highly experienced already. Most of them have 20 or more years experience by the time we train them of manual hands-on therapy experience. And almost all are physical therapists. We have clinics in LA, Dallas, St. Louis, Missouri, Michigan, up near Detroit, outside of Detroit. Gainesville, Florida is our central location. There's one in Manhattan. She's had so many successes. And we have a location in North London in England.
Ooh,
so we have
England.
6 at this point.
Right.
in the beginning, we realized that people, how are we going to treat people? I mean, they're going to have to travel, and in physical therapy, you're generally seeing people 3 times a week, and then you go down to twice a week, and then to once a week, but couldn't ask people to stay for months. So as it happened, one of the physicians in town, as a radiologist, was seeing all these blocked fallopian tubes we were opening, and he called his father, who was a senior researcher at the National Institutes of Health. And his father got real fascinated, moved down here to study us. And I said, Dr. Wickman, I'd like to know I don't know how do I judge how many hours it takes? And also, can we do this quicker? Can we do it in a week, in 5 days? And he examined all of this. We had done several hundred patients by then, and he looked at their data. And he said, you average 16.2 hours for opening blocked fallopian tubes. It's probably the most challenging. So we designed a 20-hour program where people fly in on Sunday afternoon. They come into the clinic on Monday morning. They get 2 hours of therapy in the morning, a break for lunch, 2 hours in the afternoon. They're free to walk around. We like and encourage them to walk. To keep things moving, as you had alluded to, because movement is so important. And we do those 4 hours Monday through Friday, and they're done Friday afternoon. And I asked Dr. Wickman what the success rates are for the ones that are local that we spread over up to 2 months and just did an hour here and an hour there, and the ones that we treated in an intensive, and it was virtually identical. He said,
oh, well,
statistically,
that's excellent news.
Yeah. So most people fly in on a weekend. They start on Monday morning and they're done Friday afternoon. We try to quit early so they can catch plane back home Friday afternoon if they choose to, or they can stay and enjoy the area. And that's what all of our studies are based on, that 20-hour protocol.
Interesting. So
you're quite mobile during that time. You're able to do all this stuff. You might get a little bit sore. Might want to take some ibuprofen or Epsom salt bath. Other than that, there's really not been a problem.
And are the clinics that you mentioned in Texas and New York and LA, are they independently owned by practitioners you've trained and they do something similar, or do they do your same week-long 20-hour protocol?
All of them in the USA are owned by us.
Okay.
And they're people that we've trained, and they're only treating our patients. The one in London they're excellent therapists, but they have a busy practice already. But they got fascinated with what we were doing. So we met them in Rome and tested them and checked them out. They checked us out, and we said, wow, you guys are really good. You could learn this. So they have incorporated our work into their practice, but they still do the same 20-hour protocol.
There seems to be a burgeoning interest and extra training in physical therapy in the realm of pelvic floor therapy and women's health, which I mean, perhaps it seems like it's newer interest, but it just seems so much more accessible. How different is what somebody might get out of a pelvic floor visit different from what you're describing in this adhesion work?
Very different. That we've just been, I mean, this has been our focus, adhesions, for about 35 years now, and fertility for about 33 years. So that's been our focus. The many physical therapists are interested in how the muscles are working. Here, let me put a couple of fingers inside of you, squeeze. Okay, you're a 2 out of 5. Now I want you to do a bunch of Kegels. And okay, now you're a 3 out of 5 next week or the week after. So they're not really thinking in the same realm that we are. Not that they aren't good.
It's a different thing.
That's right. It's just a different thing.
Like auto body work versus engine care.
Right. That's it. Yeah. Well,
both are important and necessary. Okay, great.
Yeah.
Do you see like an overlay of women that have been victims of sexual abuse and trauma with this type of extra layer of adhesions and difficulty with this? Because, you know, we're learning more and more, and I don't think we know enough about how the body holds the score in terms of trauma. But I can only imagine that there could be, beyond physical injury, like a trauma response in
That's
the area
exactly
of tissues
what
that
I
have
was
been
thinking as you were describing this deep work. I was just imagining
somebody that might have
certain
been
places once you access it, that emotion would just flood out of women,
Yeah.
and that people would be crying or feeling rage, or there would be a lot of emotion.
Absolutely. Absolutely. And we encourage people to know that it's totally safe, that whatever goes on in here stays here. As a matter of fact, the first day of treatment, I generally tell people, I want you to start visualizing yourself walking out of here Friday afternoon with exactly the body you came for, body, mind, and spirit. Start visualizing and creating your vision for your life and where you're taking it. We do have some women that go home and divorce their husband because they're in that kind of a relationship and they realize that while they're here. A good percentage of women, I believe, and I know it from classes when we've asked, the instructors asked, how many people here have had physical or sexual abuse? And about a third of the women will raise their hands.
Pretty
and
much
there's probably another third that don't feel comfortable raising their hand, and it probably happened to too.
Or they
So I
just
think
don't
we're-
understand what sexual abuse is. I mean, people think it's like in the movies where some stranger pushes you down a flight of stairs in the parking garage and assaults
Right.
you, and it's not coercion from your high school boyfriend or whatever you might
That's
have
right.
encountered.
And of course, those kinds of events of physical and sexual abuse, even the sexual abuse ones, do cause physical scars and do cause physical damage. Besides what you had alluded to, Caitlin, the trauma, the tension, the just holding yourself in just this inner. I mean, we've seen patients who have been really, really so adhered on one side of their body because when they walked down the steps, their dad was over there, was abusing them, was over on that right side, and they just kind of would tense up as they were walking by and caused a physical manifestation that took months or years to occur. So not just from a single event. And we have seen, certainly there's plenty of that. We see women from Africa who have gone through what they call female circumcision, which is certainly
yeah.
a euphemism. It's awful.
Clitoral excision and
Yeah, the clitoral excision. So, and of course, they're not even using surgical instruments,
there's
even
like a
if it
sharp
were a
rock.
reasonable. Yeah. A Coke
Larry,
bottle.
another thought that I have that's interesting when we're talking about movement is that there is within a woman's menstrual cycle some natural movement of the cervix, distance from opening of the vaginal canal up to the cervix. We can tell fertile signs based on how much cervical fluid. And so there's not just physical movement, but fluid movement. Is there a potential benefit of a time within someone's menstrual cycle to treat, like early in the menstrual cycle, after ovulation, once the cervix moves back down? Or have you seen anything regarding that in your years of experience?
Great question. We think that if we can treat someone in the first days of their period after they have stopped menstruating, then there's nothing really in the uterus. We feel like that it probably makes sense that that's a good time to get treatment. Although we've treated women all through their cycle, including during their cycle, and not had any adverse events from that, and we've seen plenty of pregnancies.
And do you have thoughts? I mean, I specialize in PCOS. We have a lot of gals that have things like adenomyosis or endometriosis. Do you have specific thoughts or takeaways or even studies in different of these infertility kind of populations and how your treatment might vary or differ based on the diagnosis they come to you with?
Yeah, I'd like to look up here. I had prepared some slides so I can look up and see what our success rates were. Because I hired this PhD and I said, I'd like you to put out a few studies on these different things. And I noticed she wasn't putting them out. And finally she said, Larry, I did a 10-year study of every infertile woman you've treated. You've got like almost 1,300 women, and I've divided them up into categories of infertility diagnosis. The PCOS pregnancy rate is 53.57. It was not a huge population in the PCOS. It was only 28 women, 15 became pregnant, 14 naturally, and 1 by IVF. But still, we had about a 54% success rate with PCOS. We have interesting numbers with FSH as well. As you know, the age of 35 is called a watershed year in which fertility is said to be decreasing each month. And each month, a woman's ovaries down in her pelvis call in the pituitary about 1.5 inches inside your head to release follicle stimulating hormone to help these follicles grow. And even when a person goes for IVF, they'll test FSH, and if the FSH levels are higher than 10, they say, well, no, your ovary is asking for too much FSH. You're almost menopausal. This isn't going to work for you. So we had in that population of women that she studied over 10 years, we had quite a few that had high FSH. They were supposed to be totally infertile due to age, basically.
Or premature ovarian failure, just higher FSH in a younger woman.
Right. And for 39% of them became pregnant when we treated them. None were supposed to become pregnant. So that was a really good sign. We know because we treat the full body, even though we're spending probably 60 to 70% of our time between your umbilicus, between your belly button and your knees. We're spending the rest of the time going up the back, up the chest, into the neck, into the head, working with the cranial bones, and your pituitary sits in the middle of a bone called the sphenoid, which articulates and rocks back and forth. And we think that the sphenoid, the pituitary, gets some vitality out of that rocking back and forth, because we'll see people where one of the bones under the ear is lower than the other, so the cranial bones have shifted and it puts pressure up on that pituitary. When we treat the whole pelvic area and then come up into the neck and the head and treat the cranial bones to get those balanced, that's where we see the dramatic improvements in women that have high FSH.
Interesting.
So, yeah.
What about endometriosis?
Endometriosis, when it first started happening, this woman said, oh my God, my period came and went and I didn't even know it was coming. It's amazing. I'm always on the ground with in pain for 2 or 3 days. And it was very early in our career for Belinda and I, because we were treating other things before this. She said, because I have endometriosis. And the woman left and we turned to each other and said, what's endometriosis? Because we know that we treat adhesions. Well, we think what occurs, we know that wherever endometrial tissue lands in the body, adhesions generally form.
Mm-hmm.
And as the endometrial tissue swells each month with your period, we think what's happening is it's pulling on those adhesions, and that's where the pain is coming from. We don't do anything with the endometriosis, we think. We don't know, but we know that we decrease adhesions.
Endometrioma is not being changed, but the adhesion it's creating is what's changed.
That's right.
Okay.
So if we are detaching those little 2,000 pound a square inch bonds, which is 140 kilos a square centimeter for anybody not on the U.S. system, is when we detach those, then those tissues can swell. That endometrial tissue can swell and shrink, and it's no pain. So we do have endometriosis success rates too here, by the way.
Let's hear it.
The endometriosis success rates for that study, she inadvertently included women with totally blocked fallopian tubes, but our endometriosis pregnancy rate is 43%.
Okay.
for women who were diagnosed infertile with endometriosis, some of whom also had blocked fallopian tubes. So that's pretty good for
That's amazing.
compared
Yeah,
to
that's better
having
than
a
you'll find anywhere
surgery.
else. That's for sure.
Actually, the surgical success
Wow.
rates are here too, but and they're a little bit lower. They're actually quite a bit lower.
So, when we think about somebody actually accessing this treatment, since at least the US based clinics that you're in control of, all of them do this 20-hour intensive, can people also choose, if they're local to you, to do a more extended period of time so
Oh,
that
yeah.
maybe they're not taking like a week off work to do it that way that you have available for out of town?
We'd like to
clients?
do 20 hours within 2 months, and most
Okay.
people do it in 5 days, but the locals can spread it out. And some people come in for 2 hours at the end of the day,
And what kind of
once a week.
financial investment, aside from travel and hotel accommodations and that kind of thing, what is somebody looking at to access this treatment?
The full program is $6,500, which is about less than half the price of an IVF, I guess, or about half the price. And so that's what it is. We'll work with you to see if you can get insurance reimbursement. If you have pain, we may be able to get you may be able to get some reimbursement, and we'll have conversations on our website, or our staff will be glad to talk with you about how to talk with your insurer before you come, because we would be out of network providers, but so we are a cash practice. It's the only way we've been able to survive.
Hey, you're
That's
talking
right.
to two cash practices right here, so we
Yeah.
hear you loud and clear.
Yeah,
Well, and frankly, a lot of IVF is cash practice because,
that's right.
most
Almost
insurance in most places doesn't cover IVF. So when you're talking about treatment modalities, therapies, and success rates, I haven't heard success rates in IVF similar to what you're describing.
Yeah, not at all.
I mean, let's
true.
just call a spade if we're going to talk about options, and maybe this is a less invasive one, but I don't know.
It's
You're telling
certainly
me,
less invasive, less risk. I'll tell you that.
but talk to me about somebody laying there on your table. I mean, what is the pain threshold? I understand that people's sensation of pain may be different, but if you're working on adhesions that are uncomfortable to begin with, potentially, or bound, what is it like for somebody who's laying on the table and you're really working through this work? What's the pain like?
We'd like to stay within everyone's tolerance level. So we'll say, 0 to 10, tell us when it's a 6, or tell us when. First of all, don't take any narcotics, please, before you come in. If you are taking narcotic pain medications, we'd like to get a real sense of what your pain is. But if it's bothering you too much and you feel like you're tensing up, please tell us, and we'll lighten up, and we do it immediately. So it's not what I would generally call comfortable, but it's at the same time satisfying, because when they get up, they can feel, oh my gosh, I can stand
Yeah,
up taller, because these things will pull you down.
Right. I've had really intensive body work that has not been comfortable to live through, but it has been productive and worthwhile. And so, if it falls in that category, if I were in a position where this was something that sounded promising for me, I would be willing to kind of endure that. But so let's say somebody is in Eugene, Oregon. So you're not near one of your centers, and they're listening to this and they're like, hey, this is kind of interesting. I'm drawn to this. I think this might be a good option for me. What are their next steps?
So best thing is to go to our website, clearpassage.com. So just clearpassage.com, and complete a medical history questionnaire. It'll take about 20 minutes to complete that. So we can look at it and we can say, oh, this is somebody that we think we can help. This is why. We see a potential problem here. We see a risk or a contraindication. There are not many contraindications, but if there's an active infection or a large endometrioma, we may wait for the infection to pass. We will wait for the infection to pass, or may need clearance from a physician. And then they can schedule a telephone conversation, having completed a medical history form. It does not cost anything. We can figure out together whether this makes sense for you. We're not a big sales organization. We're not trying to rush people in. Yeah, we love what we do and we're excited about it. But we realize that it costs money and you have to take a week off work, maybe, and to fly to Pasadena for the one in Eugene, Oregon, or to Dallas. And so there's that. So it's a real low pressure. So that's basically the process. If a woman in Eugene, Oregon completes her medical history questionnaire and sends it in within 3 days, generally quicker even, business days, we'll get back with her. And she wants to schedule a conversation with one of our directors, well, she's going to be talking directly with a physical therapist who's been doing this for years. Okay. So that's it.
Let's take our last station break, and then we'll start to wrap up this episode with a couple more questions, and we'll do our yeah, girl, or in your case, our my man, or I don't know, whatever we're gonna call it. We're taking a break to talk about our sponsor, Fertility Cloud. In working with hundreds of you ladies, we have noticed a problem that has come up. I know it's come up for me, Caitlin. It's come up for your clients as well. And that is not only finding a doctor who is going to know how to help you, but one that wants to. We have a lot of issues here, and sometimes getting a simple blood test or actually getting a medication or talking to someone who's actually an expert in fertility can not only take an insane amount of time, but it can feel like you're fighting your doctor.
Yeah, or you're playing like Russian roulette to get in front of somebody who actually cares. We are so excited to be partnering with Fertility Cloud because they have a solution for all of these frustrations. Just last week, I had a client that needed right now care, and we couldn't get her in front of an OB. And she got a same-day appointment with Fertility Cloud and spoke to a reproductive endocrinologist and had a prescription that she needed in her hand hours later. This is a solution that our industry desperately needs, and we are so excited to present to you.
So if you're in a remote area and you have to drive 4 hours to go see a doctor, or if you've been to multiple doctors and none of them seem to really listen or really care or want to take an approach that works for you, start up with My Fertility Cloud.
My Fertility Cloud has provided us a link, so check it out in the show notes. That will get you $25 off your first visit with one of their providers. Guys, I am so excited to tell you that the PCOS app is sponsoring this podcast episode. The PCOS app is a one-stop shop for all things PCOS. It's also your meal guide and inspo all in one. If you love listening to me on this podcast and you feel like, hey, I want Caitlin to be in my ear every day encouraging me about how to manage my PCOS, then you have to go download the PCOS app. We have curated articles to answer questions that you have about PCOS. There are short snippets in the PCOS Answers podcast exclusive to the PCOS app. We also have recipes where I not only give you the recipe, but teach you within the recipe itself what I have done to make it more blood sugar and hormone supporting so that you can take your own recipes and make them more PCOS friendly. If you've been looking for the Google of all things PCOS, with the filter of compassion and expertise that you get from Caitlin Johnson, RD, then you have found it in the PCOS app. Head to your Android or Apple store today, download it, and let's hang out.
Okay, so Larry, who is the ideal candidate for this type of therapy? Who would really benefit from this? And maybe on the flip side, who is someone that you think would maybe not have much success and should look into other avenues?
Okay. The women who would benefit would be women certainly with blocked fallopian tubes, even with swollen tubes. So if you've been
diagnosed with tube dysfunction of any kind.
That's correct.
Okay.
If you have pain with intercourse or unexplained pain, where doctors just can't figure out where the pain is coming from, usually that's adhesions because they do not show up on diagnostic tests. if you are considering an IVF, our success rates are 50% higher for success with IVF, especially in women that are over 40. The success rate is 5 to 9 times the national average for IVF.
So if IVF is going to be a part of your equation, going and spending a week with one of your practitioners before going down the road of IVF is just sort of like priming the pump for this to be more successful. Right. Okay.
Is that for retrieval as well, or just before transfer?
Before starting the cycle.
So before...
Within 15 months before starting a cycle.
Okay.
The start of the cycle is when they give you the drugs to stop
IVF
your period.
itself is different from the transfer. So, so before the
That's
IVF,
true.
Before we're going to retrieve and fertilize. Okay.
Mm-hmm.
Got it.
That's right. So, certainly if you have pain with intercourse, or you're having sexual dysfunction,
and it's affecting your day-to-day life.
Yeah, or tailbone pain. Oh, God.
I'm thinking I need it.
I know.
Larry,
Caitlin and I are ready to go on like a med vacation to Florida.
Let's do it. Let's do it together. That should be our next. Let's do our next podcast. Place.
Okay, we're going to do it. Larry, are you still seeing patients personally?
I would.
You would?
I would. Yeah. We made the cut.
Yeah, they keep me busy. I'm a little bit older now.
Well, that was,
ladies and gentlemen, Larry
question.
He is
very
in his 70s. He is,
yes.
I'd imagine, with all of these practices, has moved into more of a medical director role and is perhaps not as hands-on and bedside as he once was. So we're not saying he's, some obsolete dinosaur, but we're just saying that, like, as your practice grows, just like with Caitlin and I, as your practice grows and flourishes, the founder naturally steps into a more of a medical advisor role, medical director role.
But Larry, I have that question. Like, what if somebody listens to this podcast 10 years from now? Is there a long-term plan that your practices and discoveries and treatment modalities are going to continue beyond
this is your legacy,
your healthful years?
Yes, we don't have kids. They've totally fried her reproductive system with all that radiation.
Damn.
So we're going to be leaving our practice to our staff, and we're training them to take that over and to keep running it. And we have training sessions that we've designed and such like that. So we may actually open as an adjunct for some in vitro fertilization doctors in their clinic. It's a natural fit. They've always regarded us as competition, but heck, we're all trying to help. I'm really glad you say that
this is not competition. This is compliments. This complements each other.
That's right.
And Sophia and I see that all day long.
We do. It does not have to be one or the other. I used medicine to become pregnant with my first baby. I am not sitting here saying... I actually had surgery to prepare for my first baby. I had endometrial polyps that needed to be removed. And so we're not saying that you're wrong, bad, stupid, antiquated, whatever, lazy. If you're using these other technologies, these other medical treatments to build your family, you can do both. You can have complementary medicine and increase your chances of the medicine actually working. And this exactly the same for PCOS. Like, if you're going to be using ovulation induction with PCOS, let me tell you, it's not going to work that well if you aren't doing the diet and lifestyle stuff leading up to it. It's going to be so much more successful.
And always going back to the point of, we're not just trying to get pregnant.
Exactly. We're trying to have a healthy pregnancy, a healthy baby, a healthy family, a full life.
There you go.
That's
it.
Well, all right. What was the other question we wanted to ask Larry? Caitlin has the list over there. What else do we got?
That was it.
Oh, who would be the person that you would not be like, they can just rule themselves out right now? Or maybe not completely, but who would you maybe say wouldn't be a very good candidate for this kind of treatment?
The ones who are not the best candidates are probably, it's more of a physical condition where we are using our hands to get in. We need to be able to access those organs. People who are very obese, that have BMI over 35, we would like you to lose some weight get to 35 or under so that we can reach everything. So that's one. Other than that, I really can't think of any. If you have a large endometrioma, which is a fluid-filled sac that's full of endometrial blood, basically, we don't want to treat you until that has been surgically removed, because we don't want to burst that and spread endometriosis throughout your pelvis. So we'll be looking for that. So when people apply, we will help them. And like you, we're not against anything. Whatever. I think people need to follow their hearts and follow their best intuitions. We will have a consult with you, and we'll talk to you about us, and we'll talk to you about other things. We'll be glad to. We're not going to be putting down IVF or any choices. We, like you, in your philosophy, we think of the full body, and that's why we treat the full body. And that's why we got up into treating the cranium. And we found that people that had severe headaches would have to bring their tailbone back so that it would free up, it would stop the pull of the dura all the way up to the base of the skull.
Caitlin's like adjusting her neck right now talking about it. She's like, oh my gosh.
My physical therapist has me do these like
chin tucks.
I call them the double chin tucks, where you bring your head all the way back. Anybody on social media with a phone needs to do that.
Let's be.
Don't I always? With
I was just talking to Caitlin about that yesterday. I was like, do you ever do this where you try to make as many chins as possible? And she said no. And now here she is doing the same.
Well, okay. Do I ever do this to try and make as many chins as possible? I intentionally do not try to make extra chins. However, I do pull my neck back for a physical therapy exercise.
I'm so glad we have video on this now. You guys are just getting the full experience. Look at how many chins we can make.
Because so many headaches. I mean, the base of the skull seems to be the keystone place for unlocking so many headaches. And if we can't get it by tractioning there, and get your guy or your gal to traction there, and if we can't get it from there, then we're liable to suggest, we need to go in vaginally or rectally, I think, and bring your tailbone back, because your tailbone is the south end of the dura, which surrounds your entire spinal cord, has no play in it, all the way up to here. So if we can bring it back a half inch, and it can give you an extra half inch of mobility up there.
Getting a little slack in the rope.
The people that were going to the ER for the men that were going to the emergency room with severe headaches, we couldn't get rid of the headaches when we started doing that with them. It broke the headache cycle, and they stopped going to the emergency room.
So you see men too.
Yeah.
Awesome.
Well, Larry, this has been quite the experience. I'm so glad to have you on here. I think we probably need to start tying a bow on this episode. But let's do our yeah girl or my man is what we're going to call it when men come on here.
Larry, this is just when we celebrate anything you want to celebrate today. Professional, personal.
Yeah, it can be anything from we've opened a new clinic and we're, having all these wonderful developments business-wise to I found the best breakfast burrito and I had it today or whatever. You can decide, and anywhere in between, no wrong answers. So, Caitlin, do you want to go first, second, third? Okay, you go first.
My girl today is I'm working on redeveloping the Find Fertility course to be more DIY. In the past, it's been very much like, go do this, bring me your results back. I interpret for you and help you along the way. And I'm trying to reduce that so that we can reduce the price and just get it in more people's hands.
Sure.
And so today, literally, I had 5 minutes in between recording the new version of week 1 and this call. And I was really nervous about it last night.
Oh my God, what was that?
A sneeze.
Oh.
A background sneeze.
It's like
I was really nervous about it last night.
Sneeze.
And then
Belinda is just like Caitlin. Photobombing this episode.
Sound bombing. I was really nervous about it, but it was, Sophia and I do this a lot where we'll have like a season break, then we come back for an episode or something. And it was just so exciting to get live with people again because we're recording it live. And I just like my fire for it and my anxiety and nervousness around it went down 100%. And I know the next 11 weeks of recording live with people, it's just going to be so much fun because I'm like walking in my calling. And I feel like this whole episode is like watching Larry, who didn't get the privilege of being a parent of his own biological children. Has helped so many people have that privilege. And it's like you're walking in this calling, Larry. And it's almost like once you get into it, you can't imagine your life doing anything else. What a beautiful thing. And I feel that too today. And I just feel like it's worth celebrating.
That is worth celebrating. Hooray.
That's very nice.
Oh, and
Very
another
beautiful.
girl, Sophia and I are planning a very fun thing, and she dropped a hint on it on Instagram
You're
yesterday.
stealing my girl. Okay, go.
Oh, sorry.
No, you do it. Take it. I got other ones.
Already somebody wrote me and they're like, I don't care where, when, or what it costs, I'm coming. And so I can't wait.
It's going to be in Florida and we're going to Larry's house. No.
No. Well, maybe that's version 2.
We're going to go meet Belinda and stir some tea. We're gonna do
There you go. There you go.
Well, yeah, girl, I love that. So I'll piggyback on that. Well, that was going to be my girl, is Caitlin and I are in the burgeoning, the fledgling, the very beginning stages of putting together a fertility-focused retreat for you, our listeners, to come away with us for the weekend for a couple days. We'll hang out, we'll get body work, we'll do cooking stuff, food stuff, exercise stuff, meditation stuff, journaling stuff, and just fun stuff together. And we'll get to meet you face to face because just like what Caitlin said, you are our favorite part of what we do. You, the listener, you, the woman who is building her family right alongside us, you are our favorite part. You are why we hire babysitters to watch our kids. You are why we're not at the zoo with our families right now. You are why we do what we do. You are worth it. And we want more time with you. So that's our Yeah Girl. And the other piece of the Yeah Girl is I have a dear, dear friend. My husband and I is like best friends. Remember when I was telling my first birth story and I was like, this family was staying with us because they were getting fertility treatments? Well, those fertility treatments were a bust, unfortunately. However, they are now pregnant in the wild.
Yeah.
Yes. With a baby that we just got the first ultrasound images of, 13 weeks along, strong, healthy baby doing great. And this is like, it is such an answer to prayer for me. Such a joy, such a miracle in every way. Oh my gosh, my heart is beaming for them. And I am just so very thrilled about this. And they didn't want to do early scans, 8-week scans and stuff. There's risk associated with that. And they wanted to wait a little longer before getting any imaging done. And so we finally see, because this is after losses and everything, that there is a baby cooking in there. And so we are so excited. And that is my Yeah Girl. It's a Yeah Girl for me.
Yeah.
Because
mama.
Yes, this is a baby that I get to love all my life, and I don't have to be pregnant with it. So great. So that's my Yeah Girl. All right, Larry, let's hear your my man.
All right, my man then is, all right, so after doing this for 35 years, we've got over 1,000 babies born, we would meet with doctors, and it really was frustrating because these reproductive physicians would get so excited about what we were doing and then I think they would
like the light bulb went on.
Wait a minute, this is going to take away my business. So,
shut the hell up.
So
no.
Then I would hear from patients, oh no, that'll never work. And even though they got so excited, so we decided that one way or another, and I need to get it out there, and also, as you had both alluded, I think, to get it into a bit more of the medical community, to create some ways to bring this into reproductive physicians' clinics so that it can be something that they offer themselves, where we would train the therapist, would help them find the therapist, would train the therapist, and give the medical cloud. It's funny because I went to National Institutes of Health and I designed a study about opening blocked fallopian tubes, and talked to someone very high up in women's health there, and she got so excited. You're opening tubes and you're helping endometriosis and intercourse pain and sexual function. Design a study, get a group together from a school. She needs some academics, and we had a group from Harvard that said, "Oh, let's do that, and let's do it on blocked fallopian tubes." And when I called her a month before we were submitting, she said, "Yeah, I don't know if we're going to do this." And I said, "What do you mean? Well, why?" I called her back. I was so shocked. She said, "Mr. Wurn, you have to understand, I'm a reproductive endocrinologist. I do IVF. There already is a cure for blocked fallopian tubes. It's called IVF." And I thought,
did you punch her in her stupid mouth when
I
she
was
said
so
that?
shocked.
Did you punch her in her baby maker fallopian tube?
I'm going to make some adhesions on you. Oh, I'm sweating over here listening to this.
I was so stunned. So, we were on the phone. So, but I think to be able to go back to that, now that I understand a bit more of what runs medicine, and so many of these physicians are actually very caring, to find those reproductive physicians, go into their clinics, set up some clear passage, and so that we have more than half a dozen places in the USA, so that we have 20 in the USA or 30, have physician oversight and work with them closely to create a full body approach. Because what we do is, it is exactly what you said, it's complementary. We work on a mechanical level that the doctors just don't even think about. They don't know. They're embryonic.
Love for no one to need my services to get pregnant.
Right?
Yeah. I would live in a freaking cardboard box and be broke as hell happily
if people didn't
if it
need
meant
your help.
people
could have babies.
Yes.
Yeah. Amen. How
right.
cool, Larry.
Right.
Well, that will be a prayer of ours.
Larry, coming in there, shaking it up.
There you go. Doing my best.
You're doing it. The man
One life
from Florida.
to live,
the wild, wild South.
You want to leave something beautiful behind you.
And of course, it's like, oh, this guy's coming up from Florida. Watch out. Here comes Florida man.
No, that has a whole extra layer lately.
It does.
Well, Larry, this has been delightful. It has been comforting. It has been eye-opening.
It's been
I hope
fun.
that for our clients and our listeners, that they see that this is a very viable option that they could consider. And you get a new study, you want to come back on, you just reach out. We'd love to have you again.
This was a delightful. And Belinda,
Thank
you come
you
on back in
so
and
much.
make as much noise as you want. We're all done.
All right. Okay. Get her on with me next time.
All right. Well, this has been another episode of Food Freedom and Fertility. Thank you for listening. If you liked what you heard here and think it might benefit someone else, please like us, review us, rate us, subscribe, share it with your friends. Algorithms are very real, and the more you interact with the show, the more it helps other women find us. So thank you very much, and we'll see you in the next episode.
Hey, it's Sophia. If you love the show and want to continue your health and fertility journey using our resources, head on over to foodfreedomfertility.com for show notes, links to products and services, information about our guests, and our newsletter. Again, that's foodfreedomfertility.com. Thanks for listening.